Moore, Madison McMahon Ward, Bryn Powell, and Minerve DeLille.
For the community health assessment of Humboldt Park, the total population is a little over 55,000, with whites being at 5%, Blacks being at 40.9%, and Latinos being at 52%. Household poverty rate of Humboldt Park is 32.2% compared to Chicago at 18.9%. The unemployment rate of Humboldt Park is at 17.4% compared to Chicago at 9.5%. President St. Mary and Elizabeth Medical Center performed a community health assessment in 2013 that serviced West Side neighborhoods, including Humboldt Park, and they reported that 27% of people are uninsured. 1 in 5 people use the ER as their primary source of health care. 1 in 5 people felt that the cost prevented them from seeing a doctor, and about 13% reported that they had no providers based on their insurance coverage. The number one type of insurance coverage, health insurance coverage, was private insurance, followed by Medicare, uninsured, and Medicaid. Some of the strengths of Humboldt Park include 2 hospitals, Garfield Park Behavioral Hospital, Norwegian Hospital. There is President St. Mary and Elizabeth Medical Center. There's also a few treatment facilities. Gateway is an evidence-based treatment foundation. There's the Greater Humboldt Park Community of Wellness. That's a coalition of organizations and individuals dedicated to improving the community's health. And there's also Adult and Teen Challenge, which is Christ-centered, faith-based solutions for youth, adults, and families struggling with life-controlling problems such as addiction.
So defining the health problem, what is substance use disorder? It's defined as the recurrent use of alcohol and/or drugs which causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. The opioid-related overdose deaths in Humboldt Park are 3 times higher than the rate in Chicago. And it is also ranked 4th out of 77 community areas for the highest rate of heroin possession. Humboldt Park's substance use impacts the rate of homelessness, social impairment, and risky health behavior. It was also reported by the City of Chicago in 2016 that over half of the homeless population received services for substance use, which tells us that services are definitely needed. Next. Diagnosis of substance use disorders among Humboldt Park residents indicated in high incidences of substance use disorders is caused by substance availability, substance abuse, peer pressure, and low self-efficacy, which is mediated by unstable home environments, trauma, early exposure to drugs, support systems, given that economic hardship, access to mental health care, availability of social services, knowledge of consequences of substance use, and individual resilience moderate the causes, and that genetic predisposition, existing health conditions, and history of violence exist prior to the causes. Next.
To address the health problem that was described in the previous slides, we have developed an intervention that consists of a series of educational workshops that promote wellness and recovery, disease management, financial independence, and housing stability. The intervention will take place at different substance use clinics in the Humboldt Park area. So while patients are receiving treatment, they may receive these additional educational services for our program. The goal of the intervention is to increase the quality of life and improve disease management of those diagnosed with substance use disorders in the Humboldt Park community. Next. In order to carry out this intervention, the inputs needed are educators and volunteer staff time, advertising at the substance use treatment clinics, We will need supplies and time to plan the program. We will also need funding, and we will need classroom space to host the workshops at substance use clinics. Many activities will take place. Some of those are recruitment at the substance use treatment clinics. We will have constant email communication with participants in order to offer constant support. We will promote content and educational materials. We will host peer support groups, and we will have individual and group counseling sessions. We will also have workshops on a variety of topics, which include healthy coping mechanisms, stress management, workforce development, budgeting, resume building, interview practice, and other strategies to promote wellness recovery. The outputs that we expect to have is a timeline and an intervention protocol. This will help us stay on track in the intervention. We expect to have a certain number of educational materials that will have been passed out to participants. We will have a number of staff trained to facilitate the workshops. We will have a number of participants who have completed the intervention, and we will have a certain number of workshop sessions that will have occurred during the intervention. Next. We expect to have outcomes in the short term, intermediate, and the long term. While we have many outcomes, here are a few of the outcomes that are most important. In the short term, we have an increase in knowledge of wellness techniques, an increased belief in the value of coping strategies that were taught in the educational classes, and an increase in motivation to end substance dependency in our participants. In the intermediate, we will have an increased utilization of educational health services, and we hope that our participants will implement some of the wellness strategies taught in the workshops into their daily lives after the program. In the long term, the outcome will be the rate of substance use disorder in Humboldt Park community, and we hope that we will make a positive impact on reducing that rate. Next.
Objectives are statements about the work to be done and have an immediate effect on the program participants. They are often distinguished by their short time frame. Objectives focus on the process theory or the effect, which leads there to be two types of objectives, process objectives and effect objectives. These objectives allow for guidance on the implementation of a program, which can be seen through our objectives for the educational substance use program. The following objectives that we created are based on the program goal to increase the quality of life and improve disease management of individuals with substance use disorder in Humboldt Park. The first set of objectives found here are from our community assessment plan and are true objectives. True objectives focus on the effect and focus on what the program participants will experience through receiving the program intervention services. The first objective is specific through its reduction of symptoms of substance use disorder. It is measurable through its 25% of adults with the disorder, and it is achievable through the implementation of wellness and recovery techniques. This objective is realistic through the creation of classes that are offered through our clinic and will be captured after a one-year time frame. The second true objective is specific about the 19% increase in knowledge through the 90% of the program participants, which makes it measurable. The objective is also achievable through previous intervention and data that was collected. It is realistic because of the resources available through our program, and once again, we'll have a time frame of about 1 year. Next. The second set of objectives found here are from our community needs assessment as well and our TAPS objectives. TAPS objectives are process objectives that focus on how a program is delivered by focusing on the activities of the program staff and its participants. The first TAPS objective is specific through indicating who is responsible for teaching the educational workshops to the program participants. It is measurable because it is possible to measure the substance use recovery program's progress in achieving the goal, and it is achievable because the program educators will encompass the correct skill set in order to carry out the intervention services at our program. It is realistic given the resources, as well as has a time frame of 1 year. The second TAPS objective is specific through its facilitation of 1 hour long educational classes, and measurable through the 5 classes that will be offered that promote wellness and recovery. It is achievable through its requirement of 1 class per day in the week, and realistic because the funding for the program allows for the employment of 2 health educators that will teach the class. The time frame is the end of each week. The third TAPS objective is specific through the distribution of 600 brochures, and measurable through the time frame of 100 brochures per month to program participants and community members. It is achievable by health educators who are employed by our program, and realistic in a substance use treatment clinic setting. The time frame is by the end of the 12-month period after an intervention begins. Next.
Creating a budget is important because it will help us in our planning and managing phase in ensuring that we, the program planners, deliver the program properly to our participants. In addition, the budget will also monitor the allocation of the monetary resources and how they will be used to meet the goals of the program. So the first part of the budget includes the revenues. These are funds for health programs, which includes grants from federal funding agencies, such as the Substance Abuse and Mental Health Services Administration, which is a branch of the U.S. Department of Health and Human Services, which works towards improving the quality and availability of treatment and rehab services to those who are affected by substance use disorders. So the amount of money that they have available is over $184 million. And the total amount that we requested from them was $105,000. Second of the revenues is the state and local funds, specifically from the Division of Alcoholism and Substance Abuse. From their 2018 federal fiscal year called draft, they had over $67 million available, in which we requested only $55,000 from. And lastly, in-kind donations, which are services provided to the program free of charge. Next. The second part of our budget will include our expenses, and I divide them into 2 broad categories. So the first part was human resources, and these are basically the personnel needed to carry out the program and their salaries. For example, the program coordinator, mental health counselor, and the research coordinator, which have specific total costs to their wages. And these personal costs are almost always the largest portion of any program budget, as we can see from looking at the table. The second one is physical resources, which includes facilities for our office space, material resources, items that will be used in a program, which will provide program support, such as supplies, pens, printed materials, and educational materials. Other costs will include utilities, internet, phone, and insurance. Next. So the evaluation of our program. The purpose of this evaluation is to provide us with crucial information about the success of our program. By obtaining this information, we will be able to determine the strengths and weaknesses of the program in order to make any types of changes if necessary. This evaluation will also help us determine the appropriate targets for the educational components of the program. The individuals that will be involved in the evaluation will include program participants, trained professionals who taught the educational classes, as well as those who provided therapy sessions for program participants. Individuals with expertise in program evaluations, such as consultants, because they will be helpful resources in completing a cost-benefit analysis, as well as pre- and post-data collection analysis. In order to engage community stakeholders in our evaluation, we will provide insight on the change in the data of their community and program participants. We will also invite these stakeholders the opportunity to attend these classes along with the participants in order for them to witness firsthand on what the program is accomplishing in their community. We will also allow other substance use disorder programs to join our evaluation in order to get any types of constructive criticism to better our program in the future, or as a way to unite in combating substance use disorders in the Humboldt Park community. There are 2 types of evaluation questions, which include process questions and outcome questions. Process questions can be asked such as, to what extent is the program being implemented as intended, and are participants being reached as intended? Some examples of outcome questions can be, to what extent are the workshops helping those with substance abuse disorders manage their disorder? What workshop topics were seen as the most valuable or helpful for participants? And to what extent are these workshops creating unintended consequences, such as either positive or negative effects? Our evaluation design is a one-group pre-test and post-test design. Pre-test refers to when we will obtain baseline data from participants when they are signing consent forms and before the program starts. Post-test refers to the data measures that will be recorded from the program initiation and when it finishes. We chose this design because it would allow us to compare the amount of change that we will see in our program participants and collect important outcome data for these participants before they receive the program and again after receiving the program. So by comparing the pre-test measures with the post-test measures, we will see how their quality of life increases with the help of the program and their level of engagement in managing their substance use disorders. So the data will be collected by program coordinators and research volunteers and will be stored in a locked location to avoid any type of sensitive information to be obtained by anyone outside of the program. Data will be collected by pre and post knowledge about information provided by and throughout the intervention, pre and post stress levels, numbers of times coping mechanisms have been used, skills knowledge tests, which will tell us if the participants know the skills while in the program, and collecting the data on how the skills worked outside the program, basically in their everyday lives. Lastly, we will collect data on how participants have applied skills that they have learned in regards to budgeting, employment, and maintaining stable housing. So how will we measure change and success? Generally, change can be measured in 3 ways. However, keeping our evaluation design in mind, we chose a specific formula that caters to a one sample pre-test and post-test design. This is done by calculating the pre-test and post-test difference for each individual and then averaging these scores across all participants. And by scores, we mean the measure of health outcomes for our participants. We also wanted to go a step further to process the success of our intervention by using an effectiveness ratio, which captures the amount of change achieved in relation to the amount of change planned. This is done by subtracting the pre-test score with the post-test score and dividing this value with the difference between a pre-test score and a target score. Please keep in mind that the target score is the level that our program is intended on achieving. Lastly, this effectiveness ratio is also recommended for our evaluation design of choice because it can only be applied to one group at a time, and it will provide us with important information on the overall effectiveness of our program to the target population. Next. Thank you all for taking the time to listen to our presentation. We hope that you all have a better understanding of our program plan. If you have any questions or concerns, please feel free to ask them now. Thank you.